Okay, we are going to have Antoine Schneider and Vincenzo Cantalupi, which I invite to join directly here in the podium, and I will briefly start about an introduction on adsorption as a new frontier in blood purification. Well, I can also think about an alternative title to this, which is the unmet promises of diffusion and convection. Why do we say that? Because we are well aware that both in sepsis and in AKI, there is a kind of retention syndrome determined by molecules that cannot be cleared by classic dialysis membranes and represent a causative factor for multiple organ system dysfunction or altered homeostasis. So what are the separation processes we're using in our blood purification system? Separation by a barrier, which use basically dialysis or microfiltration, ultrafiltration, and separation by a solid agent, which is the new modality called adsorption. Here you see a spectrum of retention molecules that actually may affect not only the kidney, but several different organ systems with specific symptoms that are correlated with the accumulation of these retention products that in turn also correlate with high mortality and the quality of life of patients. You know very well that diffusion coefficient decrease as molecular weight of the solute increase, but we have other components like protein binding, electrical charges, hydrophilic or lipophilic structure that may affect the capacity of removing the molecule by diffusion, and the same is true by convection. As a matter of fact, as you can see here, we have different profile of sieving for different membranes, including the so-called high cutoff membranes. DAPs and pumps in sepsis and AKI accumulate because of the inadequate clearance capacity of classic membranes. And even with the most recent high retention onset membrane, we have a limitation. So these are the molecules in the spectrum of large middle molecule, molecular weight between, let's say, 15,000 to 50,000, that may cause several of the symptoms and the toxicity of the retention syndrome. And for this reason, the proposal is to utilize an additional mechanisms of removal. We have hemodialysis with diffusion, we have hemofiltration with convection, and adsorption, we can use hemoperfusion, which has specific advantages and rationale of overcoming limitation of dialysis membranes, potential selectivity of the process of removal, and possibility of placing the sorbent in contact with blood, provided that we have a system with good hemocompatibility, mechanical strength and thermal stability, no fouling or clotting activation, and well-designed cartridges. And today we have an enormous amount of information derived from the use of a large spectrum of sorbents that can be utilized in clinical practice. And they have different indications, different compositions, and different capacity to remove different molecules. This can be done by hemoperfusion in a direct mode, as you can see here, or it can be done combining the sorbent with the dialyzer in a sort of hemoperfusion plus CRT. But also, we have the possibility to use sorbent alone or in combination in the plasma filtrate, utilizing the adsorption property of specific resins that can provide significant adsorption once you have separated plasma from blood, and then you can reconstitute the blood. So this is a quick introduction on what we can expect in the next months and years in terms of research. We have a quite a lot of discussion about adsorption in this meeting, and we will have a lot of papers coming out, especially in blood purification. We will make some focus on adsorption. I have the pleasure to have Antoine Schneider from Switzerland and Vincenzo Cantalupi from Italy, two colleagues who have specifically studied some specific aspects. And I think that Antoine Schneider has let's say, a large competence of the possibility to apply hemoadsorption therapies in acute medicine, while Vincenzo Cantalupi will speak about the possibility to expand the action of maintenance hemodialysis to acute patients and other situations. So I will start immediately with Antoine Schneider, and I will ask him to present his talk. Antoine.
Thank you very much for the invitation to this, have the opportunity to present at this meeting. Thank you, JAFRON, for organizing this symposium. So indeed, I will discuss the potential and current validation of indications of hemoadsorption in acute medicine, and we will discuss some of the aspects that Claudio Ronco has already alluded to. So I've got a few disclosures before I go on with this presentation. And indeed, hemoperfusion is a blood purification technique that relies on the separation of some of the agents in the blood through an agent that is solid, as opposed to diffusion or convection, as Professor Ronco has just alluded to. The principle, the underlying principle, is hemoadsorption. That is, the substance that you want to clear from the blood is sticking onto not the membrane, the solid agent that's in there. These techniques have been designed and utilized in the 70s, mostly in order to treat some poisoning. Special drug overdose, some special kind of intoxication. And then there was some indications that were developed that are more used in the chronic setting, and that will be discussed by the next speaker. In acute medicine, it's sort of waned in favor over the years and is become less and less used until the new generation of membranes have been proposed. The principle is very simple. Again, circulation of blood through a device that contains some adsorbent particles. So the earlier versions contained activated charcoal, which had very high affinity for water-soluble drugs. Whereas more recent proposals and more recent devices are made with resins which have a high affinity for lipophilic compounds. And these sorbent particles are made of granules, beads, or fibers that are inside a capsule cartridge. This very small size inside a cartridge enables to have a very large surface volume ratio, enabling very high contact between these sorbents and the blood. They're able to adsorb molecules. It's not based on size, but then they're able to adsorb molecules between 10 or 100 and 40,000 Daltons. And the adsorption process is really like a sticking. The molecule is sticking onto the sorbent through all sorts of different forces, hydrophobic interactions, van der Waals forces, but also ionic interactions. Several devices have been proposed and brought into the market in the last decade and previously. They're depicted here. There's basically two types, according to their whether or not they're targeting a specific device, specific substance to be removed. The PMX, which is directed to remove endotoxin from the blood, while the other cartridges are more aspecific and they are able to remove different type of molecules from the blood. And these are the ones where we'll focus more. So the polymyxin, the polymyxin B or PMX has specific sites on the fibers which have high affinity for lipopolysaccharide or endotoxin, and therefore clearing it from the blood. There is the adsorption is specific for these molecules. Whereas cartridges, such as the HA330 or the 380 that we will mention just after, are more designed for targeting other molecules. They're more designed to remove cytokines from the blood, pro and anti-inflammatory cytokines. But again, this is non-specific adsorption, with all these pros and cons, and that requires understanding on how these function. So in addition to the pro and anti-inflammatory cytokines, they can remove pathogens associated molecule patterns, damage associated molecule patterns, other molecule associated with inflammation, chemokines, but also molecules that we're not so sure that needs to be removed, such as proteins, hormones, and biles and bile acids, enzymes, and these molecules needs to be considered. Their potential removal and their strength for removal needs to be considered. Of course, medications, including antibiotics. So these are very important safety features that need to be integrated in the decision to initiate such therapy. So that's an example of a modern hemoadsorption cartridge that's available on the market. It's again filled with very small beads of a polymer that has high affinity for these molecules. And again, the blood needs to circulate through this. So as already mentioned, the blood circulates through the cartridge, and the cartridge can be integrated in all sorts of extracorporeal circuits, either through hemoperfusion, combined with CRT. That's an example here you see with different CRT devices in line with the filter, and the connection is very simple, very easy to be performed by our nurses with very minimal training. It can also be integrated in ECMO circuit or even during cardiac surgery in cardiopulmonary bypasses. So that brings us to the potential indications. And by potential, I mean for now, the level of evidence to have a widespread use of this cartridge remains limited, and we'll review this evidence for now. Potential indications are sepsis, cardiac surgery, and then other situations. Start with sepsis because that's the most common complication or most common diagnosis issue we face in intensive care unit. And you're all aware that sepsis is associated with very high activation of the immune system and very high release of pro and anti-inflammatory cytokines. And the idea of using blood purification and hemoadsorption to remove this cytokine is to remove this peak concentration, this extremely high concentration of molecules that is completely overwhelming the blood, the organism, and therefore leading to the inappropriate responses from the cells. So removing this peak and this concentration from the blood will lead to the restoration of the gradient from the infected tissue towards the blood, and therefore attracting the white blood cell onto the right direction. So this is all theoretical, but this is by removing the high peak of concentration of pro-inflammatory molecules mostly, you recreate the gradient, directing the cell towards the infected tissue and restoring the physiology. So that's all theoretical, but does that work? And for now, there's been only limited high-quality data that has been published in the topic, and particularly with sepsis. Of course, this is difficult, this is complicated. There's been one randomized control trial with 100 patients that's been published. The primary outcome was the level of interleukin-6 in the blood of the patients, and as you see from the graph on the left, there was no difference in the patient treated with hemoadsorption versus compared to those who were not in terms of the primary outcome. There was also no benefit in terms of ventilation or time course of oxygenation. Worse, there's been data suggesting worse outcomes in those patients with the cytokine hemoadsorption. Of course, this is a matched control trial, so there's limitation according to that. But the evidence so far is not so compelling. Also, the Euphrates trial that was using this time a specific endotoxin removal agent, the PMX we mentioned before, and targeting patients with elevated biomarker failed to demonstrate a benefit. I think it's very small on the slide, and I apologize, but there was no difference in the intention to treat or even in the per protocol patients. So where should we go from there? I think the question here is the patient selection. Of course, one size fits all cannot be applied to all our patients with septic shock. And of course, they're all in the different time course, different situation. And data suggesting that this could be true is coming from sub-analysis from, for instance, the Euphrates trial. If the authors restricted their analysis to those patients with elevated biomarker, but not too elevated, that is the range between 0.6 and 0.9 of endotoxin, then the intervention was associated with clinical benefit. Same thing from a nationwide observational study where the PMX seemed to be efficient in patients with a SOFA score between 7 and 12. So those patients that are sick enough to benefit from a therapy, but not too sick to die in any case, essentially. So in those patients that are too sick or not sick enough, the therapy is much less likely to work. So we need, and further research is required to identify those sweet spots, those patients that might or might not benefit from the therapy, and not just apply this to any patient coming inside the ICU with sepsis. The second family of potential indications is cardiac surgery. Of course, cardiac surgery requires, or most procedure would require cardiopulmonary bypass. This procedure is associated with systemic inflammation, release of pro- and anti-inflammatory cytokines, inducing, in the very severe case, or when it's prolonged, to a sepsis-like phenotype with vasodilatation, potentially organ dysfunction, acute kidney injury. So it's kind of a humanly induced sepsis, if we wish. And the beauty here is that we can intervene at the time where the alteration is induced, because we can, like I mentioned before, insert the adsorber directly in the cardiopulmonary bypass, and therefore blocking this cascade at the beginning. Again, the number of data published, there's been quite a few randomized trials, mostly of small size, that have been published, and the efficacy of the device still remains to be determined. These authors have demonstrated in a small 40-patient randomized control trial that the intervention, hemoadsorption during the cardiopulmonary bypass, led to physiological benefits. It decreased free hemoglobin, it decreased the concentration of complement in the blood throughout the procedure, therefore indicating less inflammation, less toxicity to the cells. But this failed to demonstrate the clinical benefit, and of course it's a very small trial. In my center, we conducted a study using hemoadsorption in patients undergoing cardiac surgery, and we found that the primary outcome here was pro- and anti-inflammatory cytokine, and we failed to demonstrate a benefit in this outcome. But here, I would like to ask you to look at the actual value, because we always look at the differential values. And in these patients, with the concentration, the peak concentration of IL-6, which is like the hallmark of the pro-inflammatory cytokines, was a median of 200 picomoles per milliliters. These are very small values. So that means in these patients, the hemoadsorption was not able to remove the inflammatory mediators from the blood, mostly because their concentration was probably too low. So that's why other authors have looked at other situations where the cytokine level would be higher, and this is typically surgery for infective endocarditis. So that's one of the largest trials. It just got published very recently. This is 300. It's a multi-center randomized controlled trial on 300 patients. with hemoadsorption versus control, and here the primary outcome was the change in SOFA before the operation, before between the intervention and the post-operative period. The patient was comparable. There was no adverse event to be noted, and that's also important because this procedure, and that's true, consistent throughout the studies, very little amount of adverse event observed. And here they observed that they were able to remove the cytokines. There is a clear difference between the blue and the red line, the intervention being the red line with a lower concentration of all these cytokines. And here again, if you look, the concentration, the peak concentration was slightly higher, but not so high than compared to our trial in Switzerland, with only a median value of 400 for IL-6. So that suggests that those patients with elevated cytokines, of course, there's a concentration-dependent effect, and the higher the molecule, the easiest, the more potential for removal. However, potentially this was efficient in terms of clearance and removal of cytokines, but it failed to demonstrate a clinical benefit. So maybe even this was not sufficient in removing cytokines from this patient. Here you see the two boxes, completely similar in terms of the change in SOFA. And of course, these are exploratory secondary outcomes, but 30-day mortalities, ICU length of stay, etc. There was no difference neither. So further studies are required with the sickest of the patients with very high cytokines, perhaps those patients with heart transplant. This one might benefit. So far we have extremely limited data, only an observational study suggesting potential benefit. I know there is a trial going on in Hungary at the moment. Maybe we will have data on this. We need more evidence on these topics. So far we know that it's easy to perform, it's safe, and it's potentially associated, if it would be associated with a benefit, it would be in the sickest patient, those with a much higher inflammatory response. One more word about cardiac surgery, and these are the patients that have another potential indication are the patients with emergency procedures, those patients that receive anticoagulant agents or antiplatelets agent, and of course they come as an emergency procedure and they don't have time to stop their chronic therapy. And this is where the hemoadsorption could help, because they would have this removal of these molecules, and this is a small study where they demonstrated a very impressive decrease in the amount of blood loss of the drainage volume perioperative associated with the intervention, the hemoadsorption during the procedure. So before I conclude, I can just briefly mention other potential indications, knowing also that the level of evidence is very low. You know that it's been attempted during COVID. This is data from Iran, where in a matched control retrospective study, the intervention, so hemoadsorption, appeared to be associated with a lower mortality rate in this study. The other larger, it's not larger, but it's a prospective randomized trial that was conducted and also compared hemoadsorption with standard therapy, did not show a benefit in outcome. But again, these are very small studies, and the patient selection is something very difficult because these patients are very heterogeneous. Then there are potential indication in burn trauma, so burn injuries associated with very high release of anti-inflammatory cytokines. There's been a animal study so far, and there's a randomized control trial that is being proposed, and also that's going to start very soon, I hope. And finally, some other more heterogeneous indications, such as pancreatitis, when it's associated with a very high lipid. There's data suggesting that hemoadsorption could remove triglyceride and cholesterol from the blood. So, and I refer here to this review from Claudio Ronco and Rinaldo Bellomo, recently published in Critical Care. What we need for the moment is more data, more research. At the moment, we've seen that it's feasible, it's safe, it's easy to perform, but which patient, when to do it, when to start. So we need to define the adequate and the optimal dosage for different disorders. We need to study the efficacy and the efficiency of the procedures. How many sessions should we do? How many cartridges? How often should we replace the cartridges? Also, the authors proposed that the future studies would report on clearance, excretion ratio, mass removal, to sort of have a knowledge base and actually really understand what we're doing when we're doing absorption. Basically understand the therapy before we move on to further randomized control trial. Of course, obviously, randomized control trial are going to establish the indications, the validity of the therapy, but before that, there's more groundwork to be performed. So that brings me to my conclusions. And we've discussed the fact that hemoadsorption could be performed either as a standalone, in line, or with ECMO, in line with CRT, ECMO, or cardiopulmonary bypass. That potential indication included septic shock, complex cardiac surgery, burns, and potentially other indications, and mostly that more research is required to establish its clinical efficacy and clinical indication. Thank you very much.
Thank you. Thank you very much, Antoine. Before we move towards the presentation of Cantalupi, I must say that this reminds me where we were 35 years ago with CRRT. Do you remember? Maybe you're too young, but Rinaldo Bellon and myself published, there is no enough evidence, we need to study more, and then we did the study on dose, anticoagulation, timing, and etc. So it is important not to get depressed because we don't have enough data, but rather to make studies to have this data. Also, it is very important that we identify the right patient and the right targets, because if you plan sometimes to find the difference in mortality 90 days after your intervention of today, the patient may die because he go out of the hospital and go under a train. So the truth is we need to identify correct target and see if the system does exactly what you ask the system to do, which is remove a target molecule, which is reducing maybe the quantity of noradrenaline, etc., etc. Now we move to another area of potential application, and Vincenzo Cantalupi will tell us, please.
Good evening to everybody. Thanks, Claudio, and thanks to JAFRON for the kind invitation. Since we have to study something more, I will try to move from the chronic to the acute setting in the next 15 minutes. I learned from Peter Stenwinkel from Karolinska that chronic kidney disease is a model of premature aging. This is the phenotype of our patients with a premature aging characterized by muscle wasting, osteoporosis, and enhanced cardiovascular risk, cardiovascular alteration. And this is due to the presence of pro-aging factors such as hyperphosphatemia or angiotensin II activation, defective anti-aging mechanisms such as clotho in particular, and the presence of persistent inflammation and oxidative stress. And inflammation in the chronic setting can be associated with the presence of tissue factors such as hypoxia or sodium overload, cellular factors such as senescence, exogenous factors including dialysis treatment, and the presence of uremic toxins. We have already heard how middle and large molecular weight uremic toxins may have a clear role in the pathogenesis of atherosclerotic damage and vascular calcification in chronic kidney disease. And we found here some inflammatory mediators, some activator of the complement cascade, some molecules that are released from adipose tissues or in particular from the gut. And we will focus in particular on these protein-bound uremic toxins called indoxyl sulfate and picaresyl sulfate that are produced by the gut microbiota and can reach the bloodstream, inducing a series of alteration in kidney cells, in particular tubular epithelial cells, but also in immune cells and other types of cells. These are the so-called albumin-bound uremic retention solutes, so in particular picresol and indoxyl sulfate, as I was saying before. And these are the levels of the two protein-bound uremic toxins in advanced stages of chronic kidney disease. So you can say the significant increase during chronic dialysis patients. And in respect to healthy individuals, indoxyl sulfate in patients with CKD is 44 higher than in healthy individuals, and the picresol sulfate is 22 higher than healthy people. Another important thing to underline is that we have a contribution of residual function to the removal of these protein-bound solutes in hemodialysis that is mainly related to the presence of tubular secretion. And one particular aspect going from the chronic to the acute setting is that also during AKI, these protein-bound uremic toxins can accumulate in the bloodstream. And as we demonstrated some years ago with Claudio Ronco group, these protein-bound uremic toxins are able to induce necropoptosis in tubular epithelial cells and the series of alterations that are related to a profibrotic phenotype, so the so-called senescence. You can see here the downregulation of one of the most important anti-aging factors, such as clotho. But why are so dangerous these protein-bound uremic toxins? Not only for the activity on the kidney, but also in the cardiovascular setting. You can see here how these papers suggest that the protein-bound uremic retention solutes, such as picresol, are associated with mortality. So higher picresol, higher mortality. And the same thing in this other study is for indoxyl sulfate. You can see that a 5% increase in risk of death for each 0.1 milligram milliliter increment in the serum level of indoxyl sulfate. So basically, these protein-bound uremic toxins coming from the gut to the bloodstream for the dysbiosis can induce a progression toward chronic kidney disease, but also some alteration at the cardiovascular system. So we have in the so-called cardiorenal syndrome, not only related to the presence of chronic kidney disease, but as I will show in the next slide, also in acute setting, so looking at what happens to the heart and the cardiovascular system following AKI, we have different theories today, including the presence of the activation of renin-angiotensin-aldosterone system, renal sympathetic nervous system, oxidative stress, endothelial dysfunction. But once again, systemic inflammation. That is obviously at a higher level of the inflammation observed in the chronic setting. But as you can see here, these protein-bound uremic toxins, such as indoxyl sulfate, picresol sulfate, are able to downregulate the expression of the anti-aging factor clotho. And clotho protects against the indoxyl sulfate-induced myocardial hypertrophy. So the decreased expression, you can see a sort of crosstalk between these protein-bound uremic toxins and clotho. And the other important thing is that during aging processes, we have also acute kidney damage. We have a downregulation of clotho, and this means the triggering of cellular senescence between cardiomyocytes, leading to apoptosis and heart failure. And another important alteration of patients in chronic kidney disease are represented by neurological complication. Let me introduce Madame Jeanne Calment, who is the longest documented lifespan in human history. She died at 122 years without a sign of cognitive decline. And she had a good life. She knew Vincent van Gogh. She lived in Ars, so she saw Van Gogh painting The Starry Night, but she also used the internet and the PlayStation. And she has different secrets. She was engaged in sports activities like tennis. I can say that she had a Mediterranean diet. She quit smoking, and the real age of 170 years. so smoking is not so important probably. But above all, she didn't experience any AKI or CKD in her life. And for this reason, probably she didn't have the so-called cognitive impairment, because both CKD and AKI for vascular and non-vascular factor are correlated with an increased risk of the so-called uremic encephalopathy and cognitive impairment. And this is mainly due to the fact that we have a release of inflammatory mediators able to destroy the blood-brain barrier integrity, allowing different uremic solutes, including picaresyl sulfate and indoxyl sulfate, to reach neurons within the brain. And this activity of the uremic toxins can lead to a so-called accelerated brain aging. And once again, as reported for the heart, also in the brain, these uremic solutes are able to downregulate the presence of anti-aging factors such as clotho and such as some neurotrophins that are essential for the maintenance of the plasticity of the brain. In particular, our group is studying this molecule that is BDNF, brain-derived neurotrophic factor, because we know that there is a correlation between cognitive dysfunction and decreased level of these neurotrophic factors in the chronic setting, but also following patients with AKI in the outpatient clinic, we observed a significant decrease of BDNF as well as clotho in patients who experienced AKI, in particular the 2-3 KD stages of AKI during hospitalization. So what we can do in the second part of my talk to reduce the detrimental activity of these protein biuremic toxins, we can reduce gut synthesis, we can have sequestration in the gastrointestinal tract, reduce proximal tubular retention, but obviously use renal replacement therapy. And we have already heard how diffusion and convection are not so performing in the clearance of these uremic toxins. So what we can do is to use a membrane, a dialysis membrane with enhanced adsorptive capacity, or to use, once again, hemoperfusion. I don't go into the principle of adsorption and hemoperfusion that have already been explained by the previous speakers, including the capacity of the hemoperfusion system device to bind specific molecules. I want to just show some results from our friend Vincenzo Panichi here in Italy, presented at the European Renal Association. And using hemoperfusion in this setting, so we are in the chronic setting, hemodialysis, and what we observed by mass spectrometry method is that after 2 months using a single hemoperfusion once a week in our chronic dialysis patients, in respect to standard hemodialysis, hemoperfusion allowed a significant reduction of both the protein biuremic toxin, indoxyl sulfate and picaresyl sulfate. So the hemoperfusion is efficient in reducing these molecules. And other studies confirmed the capacity of these hemoperfusion devices to reduce inflammatory mediators such as IL-6, TNF-alpha, to reduce beta-2 microglobulin, to reduce parathormone levels, and so to decrease inflammation, and also with an improvement of some symptoms that are typical of the chronic kidney disease patients, such as pruritus, hyperphosphatemia, and sleep disorder. For this reason, some years ago, there was a consensus development process, the so-called Shanghai Expert Consensus Interpretation, that identified for which patients in the chronic setting hemoperfusion can be indicated. And you can see here several alterations of several clinical manifestations that are typical of the chronic uremic setting, such as severe uremic pruritus, sleep disorder, protein energy consumption, macroinflammatory condition, severe secondary hyperparathyroidism, severe hyper-beta-2 microglobulin, refractory hypertension, and some alteration of the peripheral nervous system, such as restless leg syndrome and peripheral neuropathy. And so we have some indication for some recommendation to start hemoperfusion, for instance, in the presence of severe uremic pruritus with a modified Duos pruritus score higher than 12 or the VAS score higher than 8. We have the indication to treat by hemoperfusion severe uremia-related sleep disorder when we have a peaceful sleep quality index higher than 10. We have the indication to use hemoperfusion in presence of protein energy consumption with a modified quantitative subjective global assessment score higher than 20 or the malnutrition inflammation score higher than 18. And so other indication for the persistence of microinflammatory status assessed by C-reactive protein, IL-6 or TNF-alpha, severe secondary hyperparathyroidism, severe beta-2, hyper-beta-2 microglobulinemia, refractory hypertension, restless leg syndrome with a severity scale score higher than 11, and last, the uremic peripheral neuropathy. And from this consensus in Shanghai, the expert also suggests the treatment frequency of hemoperfusion with this, in this different alteration of chronic kidney disease patients. So to go to the end, I think that this consensus further clarifies the clinical application value of hemoperfusion in the chronic setting, maintenance hemodialysis patients, and provides the guidance for the reasonable and standardized treatment of hemoperfusion in this population. This consensus proves the therapeutic effect of combining hemoperfusion with hemodialysis or hemodiafiltration in the treatment or dialysis-related complication and to prevent long-term dialysis-related complication. So I think that coming from some lessons from the chronic setting is that dialysis adequacy should be no more based only on KT over V, but we should consider the kinetics of other retention solutes, such as protein biuremic toxin. Adsorption plus HD or HDF can be a good therapeutic option for end-stage renal disease. However, I hope to have convinced you that some of these molecules, in particular protein biuremic toxin, can have a role also in the acute setting, in the cardiovascular neurological alteration associated with AKI and with a possible enhancement of the removal of these toxins with hemoperfusion. Thank you.
Thank you very much. Thank you very much. Unfortunately, we don't have time for discussion. The only thing I can say is that we have a very rich research agenda, and we have many, many things to study. I can announce that Vincenzo Cantalupi and myself, Professor Panicchi, have already started some of these studies, and I really am going to be interested to see what the results will hold in the very, very next future.